Good afternoon. Thank you for your kind introduction. Today, my case is Y-complex tachycardia, a systematic approach. Let's start with a case. This is a 45-year-old lady who had on and off palpitation for years. She visited another hospital for palpitation. ECG showed Y-complex tachycardia. Echocardiogram was performed, which showed structurally normal heart. EB study was performed. A typical AVNRT was diagnosed, and slow pathway ablation was performed. However, he had recurrent Y-complex tachycardia again. Therefore, she visited our hospital. This is the ECG before the first ablation. This ECG showed a Y-complex tachycardia with LBBB morphology and left axis deviation. This is the sinus ECG before the first ablation. In this ECG, it showed a relatively short PR interval and possibly a small delta wave especially over the inferior leads. Otherwise, there was no underlying LBBB or left axis deviation. This is the ablation report in that hospital. According to the report, similar Y-complex tachycardia and LBBB could be induced. A typical AVNRT was diagnosed. However, the patient had persistent tachycardia despite extensive ablation at the Cox triangle. Therefore, they also attempted ablation at the CS roof and lateral mitral annulus. So, what will be the differential diagnosis for this patient, and what should be our management plan? Important differential diagnoses for Y-complex tachycardia include three important mechanisms. The first one would be SVT with aberrancy, which could be AVNRT, orthodromic AVRT, or AT with aberrancy. The second important mechanism would be pre-excitation or accessory pathway. The accessory pathway could participate in the tachycardia, that is antidromic AVRT, or it could be a bystander with underlying SVT. The third mechanism would be ventricular tachycardia. One important point to note is that SVT with LBB aberrancy is uncommon in structurally normal heart. This is due to the ERP property of the bundles. SVT with LBB aberrancy is much more common. Therefore, antidromic AVRT or VT should be considered in our patient. We can try to differentiate VT from SVT by Brugada algorithm, one of the most commonly used algorithms. This algorithm tries to differentiate VT from SVT by whether the ventricle is activated via the septum or not. It consists of 4 steps. The first step would be looking for any concordance in the chest leads. In our case, V1 is negative and V6 is positive. There is no positive or negative concordance in the chest lead. The second step would be RS interval in the chest lead. In our patient, the RS interval is less than 100 milliseconds. So we proceed to the third step. The third step would be looking for any AV dissociation. In this ECG, we could not see any discrete P wave, any fusion beats, or capture beats. So this ECG did not show any AV dissociation. And then we go to the last step. The last step would be looking for any atypical RBBB or LBBB morphology. To identify what is atypical, we have to know what is typical first. For normal septal conduction, the septum is activated from the left to the right. Therefore, there is a small septal R wave in V1 and a septal Q wave in V6. For typical LBBB, the septum is now activated from the right to the left. So the septal R wave in V1 should be small or absent, and there should not be any septal Q wave in V6. In our patient, the septal R wave in V1 is almost absent, and there was no septal Q wave in V6. This is consistent with typical LBBB. Also, the initial downstroke of QS in V1 is not wide or slurred. According to Brugata algorithm, this patient is more likely to have SVT than VT. However, bear in mind that no algorithm can be 100% sensitive or specific, as Brugata algorithm differentiates VT from SVT by whether the ventricle is activated by the septum or not. That means, if the patient has a septal VT or vesicular VT, it can be misclassified as SVT. If the patient had antidromic AVRT with the ventricle activated while the myocardium, it can also be misclassified as VT. So we have to have a comprehensive differential diagnosis in our mind. This table shows the differential diagnosis of Y-complex tachycardia by the three mechanisms. The table on the right-hand side shows the specific differential diagnosis for those with typical bundle branch block pattern. For Y-complex tachycardia with LBB morphology, SVT with aberrancy, Mahaim pathway, and BBRVT should be considered. Please note that all these Y-complex tachycardia with typical bundle branch block morphology could be effectively treated by catheter ablation. So for these patients, EP study and ablation should be considered, but not ICD implantation. Moreover, SVT with LBB aberrancy is uncommon in structurally normal heart. Other differential diagnoses should be actively investigated. EP study and ablation was arranged for our patient. Tachycardia was readily induced during catheter manipulation at the start of the procedure. The tachycardia ECG is exactly the same as the one before the first ablation. This is the tachycardia EGM. Actually, with this EGM, we could already rule out SVT with aberrancy. You may wonder how, so let's read it together step by step. This is a Y-complex tachycardia with LBB morphology. The earliest A is at the HIS, and the VA interval is 117 milliseconds. Up till now, you may think that SVT with aberrancy should still be one of the differential diagnoses. But actually, the timing of HIS is one of the most important diagnostic tools for Y-complex tachycardia. If we look at the EGM carefully, we can see a sharp and high-frequency signal merging inside the V. If we compare the timing of this local HIS signal to the timing of the V on the surface ECG, we could see a negative HV interval. This could already rule out SVT with aberrancy, because for conduction via the His-Purkinje system, the His must activate before the V. Even if we miss the negative HV interval, we could still derive the diagnosis step by step by EP study. This is the baseline EGM of the patient. From the baseline EGM, we could see the AH interval is normal, but the HV interval is a little bit short, although there is no obvious delta wave from the baseline ECG. Then we proceed to incremental A pacing. When we pace the A faster and faster from 600 to 500 to 400 milliseconds, first, we could see a prolongation of the AH interval due to the decremental AV nodal property. Second, we could see a shortening of the HV interval. We should already be alerted that this is not a AV nodal conduction, as the HV interval should be fixed in normal AV nodal conduction. Third, there is a prolongation of P to delta interval. This is the decremental accessory pathway already, and is unique in atriovascular Mahaim pathway, because for typical bypass tract, the P to delta should be constant. And finally, there is progressive augmentation of QRS morphology, also consistent with accessory pathway. So this is decremental accessory pathway property. This is the Mahaim pathway. Just for your reference, this is the decremental AV nodal property of another patient. As discussed, for decremental AV nodal property, the AH is prolonged, but the HV interval should be fixed, and the P to QRS interval is prolonged. There should be no augmentation of the QRS. Still remember the report of the first ablation. If we do not have Mahaim pathway in our mind, the diagnosis could be missed. This is especially true because the baseline pre-excitation of Mahaim fiber is minimal on ECG. Moreover, if the Mahaim pathway blocks much earlier than the AV node, then the progressive augmentation of the QRS and the decremental accessory pathway property could be missed. It is also reported that up to 50% of patients with Mahaim fibers have dual AV nodal property or other accessory pathways. Therefore, it is important to recognize the decremental accessory pathway property and differentiate it from decremental AV nodal property. Back to our case. After incremental A pacing, we proceed with V pacing. Ventricular pacing showed a retrograde concentric conduction consistent with Mahaim fiber, which could only conduct antegradally. SVT could be readily induced by ventricular extrastimulus. His refractory PVC during the tachycardia could advance the A and terminate the tachycardia. This also confirmed accessory pathway. However, we failed ventricular entrainment as the tachycardia always terminates during the entrainment maneuver. So this is a decremental right accessory pathway with antegrade conduction property. This is the Mahaim pathway. We map the earliest V at the anterior tricuspid annulus under atrial pacing and pre-excitation. If we look carefully, we could appreciate a small high-frequency potential there, which is the Mahaim potential. Ablation was done and pre-excitation gone within 5 seconds of ablation. Post-ablation adenosine test also confirmed no recurrence of accessory pathway. So this is a case of Mahaim accessory pathway, which was initially misdiagnosed as AVNRT with LBB aberrancy. In the late 1930s, Professor Mahaim first reported accessory pathway with nodal-like decremental conduction property. He suggested that for some accessory pathways, there were connections from AV node to RV. At that time, all decremental accessory pathways were considered as Mahaim pathways. But actually, what he described should be nodal ventricular pathway. In 1971, Professor Wellens first demonstrated the decremental property of atriovascular pathway by programmed electrical stimulation. He assumed it was the same as the fiber described by Mahaim, so he named it Mahaim pathway. In 1975, Professor Anderson proposed there were 2 varieties of decremental pathways, the nodoventricular and the vesiculoventricular pathways. However, atriovascular fiber was still not identified. At that time, all patients with refractory nodal-like decremental pathways were referred for AV nodal ablation, initially by open heart surgical ablation and later by catheter ablation. They did not realize that AV nodal ablation actually could not treat atriovascular bypass tract. Not until in 1988, Professor Klein noted in a 29-year-old patient, the patient had persistent pre-excitation despite extensive freezing of the AV nodal region, while in another patient, the accessory pathway was blocked during ice mapping at the lateral tricuspid annulus region, and the AV node remained intact. This is why he suggested that there should be a distinct subtype of decremental accessory pathway that did not involve the AV node, that is the atriovascular pathway. Actually, 10 years before Professor Klein, Professor Becker and Professor Anderson already noted the presence of accessory AV node with accessory fibers inserting into the RV. They discovered it in an Epstein's patient. However, at that time, it was not correlated with atriovascular bypass tract. After so many years of hard work, people finally identified the presence of atriovascular bypass tract, their anatomical location, and their electrophysiological property. That is why we can diagnose Mahaim pathway confidently in the EP lab now. This is the schematic diagram of atriovascular fiber. The proximal portion is the accessory AV node, which has decremental property. It is located above the anterolateral tricuspid annulus. The distal portion is inserted into the RV free wall or distal right bundle branch. In 1990, Professor Hasegrave reported successful ablation of Mahaim fibers in 3 patients. Initially, he targeted at the ventricular insertion site by endocardial DC shock, but all 3 patients had RBBB afterwards. Later, people switched from direct current ablation to radiofrequency ablation. In 1995, when Professor Hasegrave did radiofrequency ablation of the Mahaim fiber at the ventricular insertion site, he noted only change in pre-excitation, but not elimination of the Mahaim fibers. He eventually discovered this is due to the distal arborization of Mahaim fibers. Almost at the same time, Professor McClellan, Professor Nakakawa, and Professor Jackman demonstrated Mahaim potential at tricuspid annulus and the successful ablation at that region. This is why Mahaim fiber was ablated at tricuspid annulus under atrial pacing now, ideally with identification of Mahaim potential. As Mahaim pathway only conducts anticrately, we should not map the retrograde A under V pacing. Also, we should not map the distal insertion site due to the extensive arborization. Back to our case, the Mahaim potential can be mapped and successfully ablated at the anterior tricuspid annulus under atrial pacing within 5 seconds. Ladies and gentlemen, in the last 20 minutes, we have talked about the 3 important mechanisms of Y-complex tachycardia and the specific differential diagnosis for those with typical bundle branch block pattern. Bear in mind that SVT with LBB aberrancy is uncommon in young patients with structurally normal heart. Always consider differential diagnosis, especially the Mahaim pathway. Second, we have talked about the decremental property of Mahaim fiber and its diagnosis. And finally, we have talked about the interesting history of Mahaim fiber and how it guides our management. I would like to thank the EP team in United Christian Hospital and Korea University Medical Center for their guidance. Thank you very much, and I hope everyone enjoyed the case.